Welcome back to the Deep Dive, the show really engineered to cut through the noise and give you the distilled clinical knowledge you need. If you are a GP trainee, maybe facing the complexities of primary care, or perhaps prepping for that critical knowledge assessment like the AKT, well, you know that synthesizing these dense topics is just everything.
Absolutely. And today we are undertaking, I think, a really critical deep dive into osteoporosis. This condition, it's often managed primarily out in the community, doesn't it? But its complications, they land patients squarely in secondary care. So our goal today is to move beyond just the definitions and really provide that clinical scaffolding, how you assess risk quickly, how to differentiate primary from secondary disease, and maybe most importantly, how to navigate that quite nuanced pharmacological management ladder.
Okay, right. Let's unpack this then. We have to start with the absolute essence, don't we? What exactly is the pathological definition of osteoporosis?
So it's defined as a systemic skeletal disorder. That's key, systemic. It's not just about thinning bones in one spot. It affects the whole skeleton.
Mm-hmm.
And it's characterized by two really inseparable features.
Mm-hmm.
One is critically low bone mass, which is, often what we measure with DICX scans,
Mm-hmm.
and the microarchitectural deterioration of the bone tissue itself.
Ah, okay. That distinction feels vital. It's not just the amount of bone, but the actual quality, the sort of scaffolding holding it all together is failing.
Precisely. Yeah, if the microarchitecture is deteriorating, well, the structural integrity is compromised, simple as that. And the functional consequence of this structural failure, that's the definition of the clinical problem we're trying to prevent. It's vastly increased bone fragility, which translates directly into a heightened fracture risk. So if you see that classic triad systemic disorder, low mass, microarchitectural failure, you're looking squarely at osteoporosis.
Right. That really establishes the pathology clearly. So our roadmap then, it needs to be highly structured for clinical applicability, for the trainees listening.
Definitely. We'll start by analyzing what you call the ticking clock, identifying who is at risk. We'll look at non-modifiable and modifiable factors. Then we'll transition into the diagnostic pathway, the tools, the blood tests, the definitive T-score measurements. And finally, we'll dedicate, I think, significant time to the management strategy, paying really close attention to the specific mechanics and, importantly, the caveats of the pharmacological agents. That's absolutely essential for long-term GP care.
Okay, let's start right at the beginning of that consultation risk assessment. For a GP, effective history taking in this area, it really determines who gets a closer look, doesn't it? Who gets a FRAX score calculated and who needs that preventative advice, like right now. So this means separating the fixed background risks from the actionable lifestyle risks.
Absolutely. The non-modifiable factors, they're the patient's fixed background. We use these to calculate that sort of baseline risk profile.
And the most significant contributors here, I guess, are age and sex. Those are universally recognized, right?
They are definitely the primary demographic drivers, yes. Female sex and increasing age are, well, they're non-negotiable risk factors.
Yeah.
But we also have to look for hormonal events that can accelerate bone loss. Things like early menopause, specifically defined as before age 45, or really any form of underlying hypogonadism in either sex. Bone density is just directly maintained by sex hormones. So when those levels drop prematurely or they're persistently low, bone density can really plummet.
Okay, and when we're digging into family history, is the risk specific? Like, does a general family history of osteoporosis carry the same weight as, say, a history of a specific type of fracture?
That's a good point. The evidence actually specifies that a family history of hip fracture in a parent is a key high-consequence non-modifiable factor. This often gets weighted more heavily in the risk calculators, probably because it suggests a potentially stronger genetic or perhaps architectural predisposition to the most lethal type of fracture. And we also have to acknowledge demographic differences. We know that higher risk is specifically observed in white and Asian populations. So this fixed canvas, it helps us triage who needs maybe more aggressive surveillance. Right. Okay. Now let's pivot to the factors where we as clinicians can actually intervene, the modifiable risks. This is really where primary care can potentially prevent the onset of severe disease. Yeah, and this list largely covers lifestyle, diet, and, importantly, iatrogenic harms. First up is body weight low BMI. Is a major risk factor. We have a very specific cutoff here. Low BMI, defined as less than 19 kilograms of fat. This is important because, well, both fat mass and mechanical loading seem to contribute positively to bone density.
So that specific BMI cutoff, less than 19, that's a critical data point for the AKT exam and for those screening calculations, isn't it?
It absolutely is, yeah. Next, we've got the lifestyle toxins. Heavy smoking and excessive alcohol consumption, Both of those are directly deleterious to the osteoblasts, the bone-building cells.
Hmm.
Furthermore, a sedentary lifestyle, well, it just fails to provide the necessary mechanical load that signals to the body to maintain bone density. It's a classic use-it-or-lose-it scenario, really.
And of course, the raw materials themselves.
Exactly. Poor diet, leading to consistently low calcium intake or overt vitamin D deficiency, is a major modifiable area. We need adequate calcium for matrix mineralization and, crucially, vitamin D for the intestinal absorption of that calcium. Can't have one without the other working properly.
Okay, here's arguably the most clinically crucial risk for trainees, I think, iatrogenic risk, specifically long-term glucocorticoid use. We prescribe these all the time for common conditions, COPD, asthma, various inflammatory diseases, but the bone penalty is severe. How specifically do steroids actually, wreck bone health?
Yeah, this is a really high-yield clinical point. Glucocorticoids are devastating for bone, primarily because they rapidly shift the balance of the bone remodeling unit. Quite dramatic. They don't just reduce calcium absorption from the gut, they actively inhibit the function of the osteoblasts, those cells responsible for building new bone. And simultaneously, they may actually increase the lifespan of osteoclasts, the bone-resorbing cells. So this disruption of the bone remodeling cycle, where formation just cannot keep pace with resorption, it happens fast. Therefore, when you're initiating long-term steroid therapy, proactive bone protection, often including a baseline DEXA scan and maybe prophylactic bisphosphonates, is pretty much a clinical requirement to mitigate this iatrogenic acceleration of bone loss.
Wow, okay. So when we put these two lists together, the fixed risks and these modifiable harms, what's the net result for the clinician sitting in the room?
Well, the clinical result is the ability to quantify risk, really. Screening tools like FRAX and Q-fracture, they integrate these weighted variables, age, sex, BMI under 19, family history of hip fracture, steroid use, etc., to generate a unified 10-year probability of a major osteoporotic fracture. And this moves the assessment from sort of qualitative guessing to quantifiable risk management. It drives us toward the next logical step, which is either definitive diagnosis or targeted intervention.
So we've established the risks, but the real clinical challenge, surely, is finding this disease before the patient finds us with a catastrophic fracture. Let's talk about why we call osteoporosis the silent killer of bone density, and what those first clinical warning signs, if any, truly look like.
It is silent, largely because there are virtually no symptoms until that first structural failure occurs. That fragility fracture is the primary clinical presentation, often, which is, a major diagnostic hurdle in preventative medicine. We really want to catch the T-score drop before the bone breaks.
Okay, let's detail the anatomy of failure then. Where do these fragility fractures most typically happen?
The three classical sites, the ones you really need to know, for osteoporotic fragility fracture are the vertebrae, the hip, specifically the proximal femur, and the wrist, the classic columnus fracture. Now, while a wrist fracture is usually lower consequence, relatively speaking, the hip fracture carries just this overwhelming burden of morbidity and mortality.
And the vertebral fractures. These often seem more insidious, don't they? How should a GP spot those subtle indicators?
Vertebral fractures are definitely challenging. Yes, they can present acutely with severe back pain after maybe minimal trauma, but more often they're gradual or even asymptomatic. The subtle yet critical indicators we need to look for in an older patient include things like progressive loss of height over time, often noticed by family members or maybe during annual checks, and the development of kyphosis, that increasing forward curvature of the spine. Recognizing this gradual slump in a high-risk patient, well, that has to trigger immediate investigation.
Okay, so we essentially have two main groups presenting. The symptomatic patient who comes in with a fragility fracture and the high-risk asymptomatic patient identified maybe via those risk scores. This forms our diagnostic filter then.
Exactly right. That diagnostic filter dictates that we investigate those two groups.
Yeah.
Anyone presenting with a clear fragility fracture or anyone who, based on their FRAX or Q fracture scores, is deemed to have a high enough 10-year risk of fracture. And that might be even if they technically only have osteopenia on a DEXA rather than overt osteoporosis yet.
Right. Speaking of FRAX and Q fracture, what makes these tools so particularly valuable in the UK setting?
Well, their utility really lies in providing context. You see, the risk threshold for starting treatment isn't necessarily a fixed T-score for every single patient. These tools estimate the absolute 10-year fracture risk, allowing us to factor in age, sex, BMI, and all those other inputs we discussed. So if the 10-year major osteoporotic fracture risk comes out as, say, over 20%, or the hip fracture risk specifically is over 3%, that often triggers a guideline-based move towards the definitive diagnostic step, regardless of whether the patient has actually fractured yet.
And that definitive step, the gold standard for diagnosis and for staging the severity, is the DEXA scan, dual energy X-ray absorptiometry.
Correct. The DEXA scan confirms the bone mineral density, BMD, and crucially gives us the T-score. This T-score is the benchmark used globally, and it's absolutely essential knowledge for any trainee preparing for exams or practice.
Okay, let's really nail down those T-score definitions then, as they are the specific lines in the sand we absolutely need to know.
Right, so the T-score compares the patient's BMD to that of a healthy young adult reference population. It's a standard deviation score. First, a T-score of -1.0 or greater is considered normal. Nothing to worry about there usually. Second, there's the intermediate category, which we call osteopenia. This is defined as a T-score that falls between -1.0 and -2.5. Now, this patient has low bone mass, they are definitely at increased risk, and they need aggressive lifestyle modification at the very least. Finally, the definition of osteoporosis itself. This is confirmed when the T-score is equal to or less than -2.5. So T-score n=2.5. This confirms severe bone density loss, and crucially, it almost always triggers the need for pharmacological intervention.
Okay, this brings us to a really crucial step in the clinical detective work, doesn't it? A fragility fracture or a low T-score tells us what is happening, bone loss, but it doesn't necessarily tell us why. So before we jump to confirming primary, sort of age-related osteoporosis, we have a clear mandate to rule out secondary causes that might need different targeted management.
Absolutely.
Yeah.
This is probably the highest yield part of the whole investigation phase, I'd argue. If we miss an underlying secondary endocrine or systemic disorder, well, we'll end up treating the patient unsuccessfully with standard osteoporosis drugs while the root cause just continues to destroy their bone. So yes, extensive blood tests are pretty much mandatory before labeling someone with primary osteoporosis.
Okay, let's start with the specific bone biochemistry panel, calcium, phosphate, and alkaline phosphatase, or ALP. What specific patterns are we looking for there?
Well, we're hunting for metabolic abnormalities, really. For
Yeah.
example, if you see high calcium and perhaps an inappropriately normal or even high PTH parathyroid hormone level, that immediately pushes you away from simple age-related osteoporosis and makes you think very strongly about primary hyperparathyroidism. And that's a highly treatable cause of bone loss, but it often requires surgical intervention, not just bisphosphonates. Conversely, low calcium or low phosphate might suggest malabsorption issues, maybe celiac disease or severe vitamin D deficiency. ALP, alkaline phosphatase, it's generally high when there's active bone turnover or repair, so it might suggest Paget's disease if it's very highly elevated, or maybe just recent fracture healing.
So it's really about interpreting the triad together, not just looking at individual numbers in isolation. What about the systemic function checks? We look at liver and kidney health via LFTs and U+ES. Why are they important here?
Right. Liver function tests, LFTs, are vital because severe liver disease can affect vitamin D metabolism, the activation step. Urea and electrolytes, U+ES, assess renal function. And since the kidneys are absolutely central to calcium homeostasis and also the excretion of many osteoporosis drugs like the common bisphosphonates,
Right.
that compromised renal function fundamentally changes which medications we can safely use or what dose.
Okay. And the endocrine sweep. Hormones seem to be constant regulators here.
They really are. We absolutely must check thyroid function tests, TFTs. Overt or even subclinical hyperthyroidism is a well-known accelerant of bone turnover, leading to potentially rapid bone loss. And in that situation, treating the hyperthyroidism is the primary management for bone loss, not just giving bone drugs.
And we also include nutritional status, specifically vitamin D levels, which ties back nicely to those modifiable risks we talked about earlier.
Absolutely. Vitamin D deficiency is just rampant in many populations. If the patient is deficient, then adequate supplementation is completely non-negotiable. Because, look, no amount of calcium intake is going to help if the gut simply cannot absorb it efficiently due to low vitamin D.
Makes sense. And what about the full blood count, FBC? That seems a little less specific for bone health directly. Why is that included?
Yeah, the FBC is part of that comprehensive panel. It's often combined with checking inflammatory markers like ESR or perhaps serum protein electrophoresis, especially if the patient presents with, say, unexplained anemia or persistent, maybe atypical back pain. What we're doing here is screening for hematological malignancies, most notably multiple myeloma, which can directly cause melanic bone lesions and pathological fractures. So the blood work helps ensure we don't mistakenly attribute a cancer-related fracture to simple age-related density loss. It's a safety net.
Right, crucial safety net. And finally, we might turn to the sex hormones if that's indicated by the patient's age or their clinical profile.
Yes, particularly in men presenting with low trauma fractures or perhaps in younger premenopausal women where the cause isn't obvious. In those cases, we must check testosterone and/or estradiol levels. Identifying hypogonadism and then treating it with targeted hormone replacement therapy, if appropriate, can address the root cause of the secondary osteoporosis, especially if lifestyle changes alone aren't cutting it. So this extensive panel, it really serves as our essential clinical insurance policy, making sure we're treating the right disease effectively.
Okay, so diagnosis confirmed, secondary causes ruled out. We now move into the management phase. And this has to start with those foundational lifestyle changes, doesn't it, before we even think about pharmacotherapy?
Absolutely. The lifestyle management interventions, they are foundational for every patient, really, regardless of their T-score, because they improve not just bone health, but also muscle mass and balance, which helps prevent falls in the first place.
Okay, so what specific advice should the GP be giving regarding exercise? Just telling a patient to be more active feels a bit too vague, right?
It is too vague. The advice must be specific. The exercise needs to be both weight-bearing and muscle strengthening. So that means activities where the bones are supporting the body's weight, things like brisk walking, jogging, dancing, even stair climbing. And that needs to be coupled with resistance training. That could be using light weights, resistance bands, or even just body weight exercises like squats and lunges. This helps improve balance and muscle strength around the joints. The goal is really twofold. You get the mechanical loading to stimulate the bone, and you get improved musculature to prevent the fall that might cause the fracture.
Right, makes sense. Diet and substance use are the next pillars then.
Yes. A balanced diet focusing on getting adequate calcium and vitamin D intake, ideally from food sources first. And then, non-negotiable cessation of smoking and strict limitation of alcohol intake according to recommended guidelines. These actions directly remove known toxic stressors on that bone remodeling unit.
Okay. When do we actually step up to supplements? Do all osteoporosis patients automatically get calcium and vitamin D prescriptions?
No, not automatically. Supplementation should be targeted. Our guidelines generally reserve calcium and vitamin D supplementation specifically for patients where we have actually confirmed deficiency through blood tests, or perhaps documented clearly inadequate dietary intake based on the history. If a patient's diet seems adequate, then the focus should probably remain on behavioral modification rather than just adding pills.
Got it.
Yeah.
Okay, let's move to the drug therapy, the pharmacological management. For patients with confirmed osteoporosis, that's the T-score Examano 2.5, or perhaps those with high fracture risk scores, even with osteopenia, what is the clear first-line treatment?
The first line, without doubt, is the oral bisphosphonates. Drugs like alendronate or risdronate are the common ones. These are primarily anti-resorptive agents. So they work by inhibiting the activity of the osteoclast, those cells that break down bone. By doing that, they dramatically slow down the rate at which old bone is resorbed, allowing the osteoblasts, the bone builders, time to catch up and hopefully improve bone density over time.
Right. Bisphosphonates are definitely effective, but let's be honest, adherence is often a nightmare, isn't it? Primarily due to those quite complex dosing instructions. Empty stomach, sit bolt upright for 30-60 minutes, big glass of water. Considering the immense stakes here preventing a potentially fatal hip fracture, isn't poor adherence possibly the single biggest threat to this whole management pathway?
Oh, it absolutely is. You've hit the nail on the head. Compliance is the Achilles heel of oral bisphosphonates. If the patient doesn't follow those very specific instructions, they risk significant gastric irritation, esophagitis even. And worse, the drug simply isn't absorbed properly, making the treatment potentially useless. The annual persistence rates, people still taking them after a year, they are notoriously low, which is why detailed compliance counseling explaining the why is so crucial.
Okay, and what about the long-term use? These aren't necessarily forever drugs, are they? We need to talk about the concept of drug holidays.
Yes, this is another critical high-yield point for long-term GP management. It's really important. After approximately 5 years, maybe sometimes a bit less, maybe a bit more, depending on risk. But around 5 years of stable treatment with oral bisphosphonates, we absolutely must review the need for a potential drug holiday. This is done primarily to mitigate the risk of rare but potentially severe long-term side effects, like atypical femoral fractures or osteonecrosis of the jaw, ONJ. Now, if the patient's fracture risk has reduced significantly, maybe their T-score is improved, a holiday might be considered safe. If they remain at very high risk, treatment might need to continue or switch, but this formal review is mandatory. The good news is the bone benefits do persist for some time after stopping. due to the drug's long half-life within the bone matrix itself.
Okay, that's really clear. So if the patient is genuinely intolerant of the oral preparation, or maybe their renal function precludes it, or perhaps specific adherence issues just make it impossible, what are the main alternatives then?
Right. So we then pivot to alternative delivery routes, essentially. The two main alternatives listed in most guidelines are zoledronic acid, which is delivered intravenously, and denosumab, which is delivered subcutaneously, SC.
Okay, zoledronic acid, that's an annual IV infusion, right? Which presumably solves the adherence problem by taking the daily responsibility away from the patient.
Exactly. It's a very potent bisphosphonate delivered just once a year via infusion. This ensures 100% adherence, at least for that 12-month period. It's a very good option for many.
And then we have denosumab, brand name Prolia, often. This is a key alternative given biannually, so every 6 months via a subcutaneous injection. How is denosumab fundamentally different from a bisphosphonate in terms of its mechanism of action?
Ah, yes. This is a really critical distinction for clinicians to grasp. Bisphosphonates, as we said, inhibit the osteoclasts, often by inducing apoptosis or disrupting their function. Denosumab, however, is a monoclonal antibody. It specifically targets a protein called ARNK-L, that's a receptor activator of nuclear factor kappa B ligand. ARNK-L is the essential signal that tells the body to form, activate, and prolong the survival of osteoclasts. So by blocking ARNK-L, denosumab very effectively shuts down osteoclast activity. It's an extremely effective, very powerful anti-resorptive agent, but it works on a completely different biological pathway to bisphosphonates.
Okay, so given its different mechanism, does denosumab carry a different set of clinical warnings or caveats compared to the bisphosphonates?
Yes, it absolutely does. And this is perhaps the single most important caveat in modern osteoporosis management that everyone needs to be aware of. Because denosumab doesn't embed itself into the bone matrix like a bisphosphonate does, its effect is purely temporary. It relies on the drug being present. Therefore, if a patient ceases denosumab treatment, maybe they miss a dose or stop it without an immediate plan to switch to another anti-resorptive agent, usually bisphosphonate, they face a high and potentially very rapid risk of rebound vertebral fracture, sometimes multiple fractures. What happens is the bone turnover process, which was so aggressively suppressed by denosumab, it rebounds dramatically. Bone density can plummet within months of cessation. So the rule is, denosumab must always be immediately followed by a bisphosphonate, usually oral or FI, to log in the bone density gains, or else it needs to be continued indefinitely with strict adherence to the 6-monthly schedule. This is a crucial concept for safe clinical practice.
Wow. Okay. That is an absolutely essential piece of expert insight. The risk of rebound fracture on denosumab cessation is definitely non-negotiable knowledge. And finally, just briefly mention the other specialist treatments that are sometimes used.
Sure, these are generally reserved for more severe cases or specific patient populations, often initiated by specialists. You have raloxifene, which is a selective estrogen receptor modulator, or SERM. It's sometimes used, particularly in postmenopausal women, where perhaps preventing breast cancer is also a consideration, although its effect on hip fracture isn't as strong. Then there's teriparatide. This is a synthetic form of parathyroid hormone, PTH. It's unique because it's actually an anabolic agent. It actively builds new bone rather than just slowing breakdown. It's usually reserved for very severe or refractory cases, often after other treatments have failed, and typically given for a limited duration, like 24 months. And finally, hormone replacement therapy, HRT. Generally, this is used nowadays primarily for osteoporosis linked directly to premature menopause, particularly where the woman also has significant menopausal symptoms that warrant treatment anyway. It's effective for bone, but the decision is usually broader than just osteoporosis prevention alone.
Right. We really must conclude by reflecting on the immense cost of this fragility. All this clinical rigor, the FRAX scores, the DEXA scans, the blood tests, the careful drug choices, and monitoring those nuanced drug holidays. It's all ultimately aimed at preventing one thing, the fracture itself and its often profound ramifications.
Exactly. We are fundamentally fighting against the incredibly high morbidity and, sadly, mortality associated with fragility fractures, particularly, as we mentioned, the hip fracture.
Let's just put that into perspective for a moment. What really is the typical impact of a hip fracture on an older patient?
It's devastating. A hip fracture carries a mortality rate that can be as high as 30% in the first year following the event, especially in frail, older individuals with comorbidities. And for those who do survive that first year, a very significant proportion, maybe up to half or more, never actually regain their prior level of function or independence. It is often the single initiating event that precipitates a cascade into chronic frailty, frequently necessitating long-term care and leading to a severe loss of physical independence.
And the long-term impact of those, perhaps less dramatic but more common, vertebral compression fractures.
They shouldn't be underestimated either. They often lead to chronic, debilitating back pain. And this persistent pain, combined with the resultant kyphosis, or spinal curvature, causes significant functional impairment. Things like difficulty breathing deeply, sometimes difficulty eating due to abdominal compression, and generally significantly reduced mobility. And of course, this reduced mobility then feeds back into a vicious cycle by accelerating muscle wasting, sarcopenia, and increasing the risk of subsequent, potentially more severe falls and further fractures.
And beyond the purely physical trauma, the psychosocial impact must be devastating too. That's something the GP really has to address holistically, isn't it?
Oh, absolutely. The chronic pain and that often acute loss of mobility lead to just a massive loss of independence for many people. Patients may become effectively homebound, unable to manage basic self-care, or become heavily reliant on family or professional caregivers. This loss of autonomy, coupled with the constant pain, is a major driver of depression, social isolation, and an overall drastically reduced quality of life. So effective intervention, effective prevention is really not just about improving a T-score number, it's fundamentally about preserving independent, quality life years for our patients.
So, synthesizing everything we've covered today, the role of primary care is absolutely critical then in trying to interrupt this entire pathological cascade before it reaches that catastrophic endpoint of fracture.
Precisely. That's the goal. By accurately identifying those high-risk patients early on, through good history taking and using screening tools like FROX, by implementing targeted investigations to diligently rule out those secondary causes, and then by ensuring long-term adherence to these quite nuanced pharmacological pathways, including navigating the drug holiday decisions and understanding the specific risks and benefits of agents like denosumab in primary care, can directly mitigate the high rates of morbidity, mortality, and dependence that really define untreated or late diagnosed osteoporosis. It is truly high-leverage preventative medicine. Hashtag tag outright.
Well, this has been an incredibly detailed and I think really essential deep dive into osteoporosis. Let's just quickly run through the absolute must-know takeaways for your clinical practice and, of course, for revision.
Okay, key things. Remember the numerical markers. Osteoporosis confirmed is a T-score, aiding is 2.5. Low BMI risk factor is 19 kilojoules. Always conduct that clinical detective work, the comprehensive secondary investigation panel to rule out treatable underlying causes like hyperparathyroidism or hyperthyroidism before settling on primary osteoporosis. And finally, remember, oral bisphosphonates are first line, but you must counsel hard for adherence. Understand the drug holiday concept after about 5 years, and know that critical caveat about denosumab. Never, ever stop it abruptly without a clear subsequent anti-resorptive plan in place due to that rebound fracture risk.
Fantastic. That sets a really strong foundation for managing this complex condition. Before we sign off, here's a final thought for you, the listener, to perhaps explore as you apply this knowledge in your practice.
Okay, here's something to mull over. Considering the specific mechanism of glucocorticoid-induced bone loss, remember we said it actively inhibits the bone-building osteoblasts, not just increases resorption. And knowing the notoriously high rate of non-adherence to the complex regime of oral bisphosphonates. For a patient who is newly started on high-dose, long-term steroids, maybe for vasculitis or severe asthma, might a clinician be more justified in perhaps considering an alternative high-adherence route, like annual 5-zoledronic acid, much earlier in the pathway, potentially even bypassing the common adherence challenges of the first-line oral drugs altogether in that specific high-risk iatrogenic scenario?
That's a great question. It really pushes the boundaries of standard guidelines, perhaps,
Yeah.
and forces us to weigh that guaranteed adherence against the usual stepped care approach, especially when the bone insult is so aggressive. Something to definitely think about. Thank you so much for joining us on the deep dive today. We hope you can use this knowledge to elevate your practice and improve outcomes for your patients. We'll catch you next time.